here is our host, Tian Wei.
Hello and welcome to The Frontline, a World Insights special production on COVID-19, coming to you on CGTN. I'm Tian Wei. With the COVID-19 spreading worldwide, we are inviting doctors, researchers, and health experts who are working on the very front lines in China and around the world to help us analyze the global situation and control measures. Today, we are joined by four of them. In Wuhan, China, Professor Rubin, director of the Medical ICU at the Peking Union Medical College Hospital. In Boston, Professor Rubin, editor-in-chief of the New England Journal of Medicine. In Washington, D.C., Dr. Tulenko, CEO of Corvus Health, who served for the WHO and the World Bank. And last but not least, in Boston, David Jones, professor of culture of medicine at Harvard University. And first, let's talk to Professor Rubin in Wuhan, China, which is the epicenter of the COVID-19 outbreak in China. Professor Du, good morning to you.
Good morning.
So, Professor Du, let me ask you about the latest situation in China. What is your assessment? The numbers are going down in a dramatic way, but many wonder whether the number really reflects the reality. What is your take on the front line?
Well, I think the numbers reflect what we have seen here in Wuhan, in Hubei, and also in other provinces and other cities in China is a reality. The newly diagnosed cases has been decreased sharply all over China, but also majority of the hospitalized patients has been discharged back home. I think right now, all over China, we have less than 10,000 patients still hospitalized for treatment, among whom about 3,000 are still severe or critical cases.
Professor Du, you earlier argued, if I remember right, take a look at this quote, officials could have encouraged the providers to use more aggressive treatment methods for patients in critical conditions. Now, you are responsible for treating the severely ill, which is the biggest problem China is facing, at least for this stage. Tell me more about what exactly is the way to deal with it that you're taking right now.
From my own experience and from the discussion with some other colleagues, not only in China but also in Italy, we know that a proportion of patients with COVID-19 experienced respiratory failure. I think around 19% to 20% of them had signs and symptoms of respiratory failure. And among all these who developed respiratory failure, about 1/4 required either non-invasive or invasive mechanical ventilation. I should admit, especially during the initial stage, a large number of patients has been treated with high-flow nasal cannula or non-invasive ventilation just because of the shortage of the devices. We did not have enough ventilators at that time. But however, we did observe that the failure rates of non-invasive ventilation as well as the high-flow nasal cannula was quite high. And it will lead to death even after eventual intubation, endotracheal intubation, and invasive mechanical ventilation. So that's why we encourage the colleagues here to intubate their patients whenever they considered the NIV trial failed. We still strongly believe that this is the correct way to treat the most severe patients with COVID-19.
Professor Du,
Thanks.
CGTN has been collecting questions from followers on our Facebook and Twitter accounts. Here are some of those. I would like to select one for you. Have COVID-19 decreased in China, and what steps they have taken to reduce? That's a question coming from Dupinder Singh. Would you like to answer that in brief way?
Well, I do believe, just as I said yesterday afternoon in the press conference, that I think the major or the most effective measure for disease control and prevention whenever we are facing with the COVID-19 outbreak in Wuhan is that we expanded our test capability to try to test every suspected case. Whenever the patient had a positive test result, we try to quarantine them, not at home, but in the mobile cabin hospital or in the regular hospital, just to avoid more risk, higher risk of the human-to-human transmission. I do believe this is the most effective way to stop the outbreak, at least in Wuhan and in Hubei province.
Thank you very much, Professor Du. You want to stay with us. Professor Du Bin, who is the director of the Medical ICU at Peking Union Medical College and Hospital. He's joining us from Wuhan. Stay with us, and you're watching The Frontline. We're going to have more American guests joining us from now on. Now, we are joined in Wuhan once again by Professor Du Bin, Director of Medical ICU at Peking Union Medical College Hospital, and also in Boston in the U.S., Professor Eric Rubin, Editor-in-Chief of the New England Journal of Medicine. Dr. Rubin, what a pleasure to see you since World Economic Forum earlier this year.
Nice to be with you.
And you are with Professor Du Bin, of course, a key expert in the operation of ICUs on the front line against the COVID-19 in China. Professor Rubin, I want to start by asking you, you've been listening to your Chinese colleagues. What about the latest situation in the U.S.? A press conference was held earlier in the U.S., and obviously it seems more drastic measures are being taken. 2 weeks.
I think that there are many things that we have learned from Professor Du and other Chinese colleagues, some of which have been taken to heart and others have not. We are isolating people at a relatively early stage of the disease, which is hopefully going to be a good sign. But Professor Du talked about the importance of testing, and we're very far behind the curve in testing patients.
How far are we? We heard in the U.S. You are having it in, going to Costco's, at car drive-throughs. What is the number now for testing daily?
Well, it depends on where you are, and the volume is increasing. But I will give you as an example in the Boston area, in our state, the number of tests is down around 40 to 60 a day.
You've been saying this, and I quote you here, Dr. Rubin, if I could. There was a tsunami coming that we could see, you said once. And we hope that it would only go away before it reached us. Now, will that hope come into realization, Dr. Rubin?
No, I think that ignoring a tsunami is a bad idea. So now we're in the situation where we made some good moves and some not so good moves, and we now have to cope with the situation as it stands today.
Professor Du Bin from Wuhan, you heard your colleagues, Dr. Rubin, talking about the latest situation. Now, some have been describing the U.S. situation as 2 weeks ago, Italy. Professor Du, given your frontline knowledge and your from the very beginning following every step of the way in China about COVID-19, what is the best advice or experiences, suggestion you could share with your colleague?
Well, I still believe that the testing and isolation are the most effective way, and to try not to be in the same situation as what we had here in Wuhan and in Italy as well, where the local healthcare resources have been overwhelmed by the outbreak.
But Professor Du, what is it like at the very beginning, when China and you and your colleagues were rushing to the front line to aid Wuhan? How did you guys manage to get through this, first of all?
I arrived at Wuhan on January the 18th, so about more than 2 months ago. A period that I would say, I would call it the already, it's the epidemic is already transferred from the first wave into the second wave, which means that the hospital transmission has already occurred here in Wuhan. And from the other hand, I am an ICU doctor, so working primarily in the intensive care unit. And whenever we have an empty bed, either the patient was discharged, transferred to the general wards, or the patient died, unfortunately, we always have more than one patient waiting on the line, for being admitted to the ICU. I do believe that everything became better whenever the external assistance came to Wuhan. That is, they have their own, doctors and nurses coming here to help the local doctors, local medical teams. They have their own, medical supply, even though it's only adequate for a couple of days or up to 1 week, but it's a significant help to the local medics.
Dr. Rubin, we know very well that it goes like this. So it's case, until it's clusters, and then we go from clusters to cases to rather community, and then there's the boom. Okay. So what about the U.S. right now, from your assessment, first of all, and then I have a follow-up for you.
I think we're still in the relatively early part of transmission. However, there clearly is community spread. So it's not just clusters anymore. It's moving outside of clusters. Again, I'd emphasize that we're not doing enough testing. We don't have enough test kits right now to really judge the extent of the outbreak. So we're making guesses as to how many people are infected. It's clearly a lot higher than the number of people who actually have been tested positive.
Dr. Rubin, you've been following the COVID-19 pandemic from the very first stage. I remember having many discussions with you since the outbreak. Do you have some specific questions for your Chinese colleague who is now at the epicenter, whether it's about rescue or ICU operation or about the early stages protection?
Well, I think that we're in a slightly different situation than Dr. Du faced when he first went to Wuhan. He was also there in the relatively early part of the outbreak, although it had already gotten out of hand. Our preparation is different. We are very well prepared at the individual hospital level, but we're poorly prepared in terms of and better, in fact, than Wuhan was, because we have all that warning from Wuhan. But we're not so well prepared from the testing standpoint. And one of the things that I think Dr. Du can address is how rapidly China was able to scale up testing. That really helped a tremendous amount.
I just heard what the Professor Rubin told us, but however, in my mind, that for an infectious diseases such as the COVID-19, what is more important is not preparation at the hospital level. The most important issue is how to prevent and control rather than treatment.
Dr. Rubin, from the New England Journal of Medicine, you've been working with your Chinese colleagues and colleagues around the world about the latest scientific discoveries and papers. So do you see that different emphasis on whether preparations at the professional level or preparations on a societal scale, Dr. Rubin?
Well, I think I'd separate the public health response from the scientific response. The scientific response has been it lags behind. It has to necessarily, but I think it's just starting to come into play. Over the next few weeks, we should be learning a lot about what therapies might make a difference for patients, in addition to the excellent supportive care that Dr. Du was telling us about. But are there specific drugs that can help treat the coronavirus? Are there other sorts of interventions, medical interventions we can do in addition to the very good supportive care and ventilation for these patients? And I think we're going to learn more about that. Right now, we still don't have good, high-quality data to address that.
I see.
Now, I will say that a lot of the studies from which we're going to learn are going on right now in China. For most of what we'll learn is probably going to come from Chinese investigators, at least for now.
We understand the latest information suggests first human trial of vaccines could be in operation in April. So what would that mean, Professor Rubin, to your work, which is about saving lives, with the last resort at the ICU? Does it mean a whole transformation of your strategy from China's perspective?
I understand that the vaccination is one of the most important and effective way to combat the infectious diseases such as the COVID-19 and other, such as influenza. So we are expecting the success of the vaccine against COVID-19. However, from the past experience with SARS, as far as I know, that the vaccine against the SARS coronavirus was a failure trial. So vaccination is the only effective way, but not necessarily for novel coronavirus. So there's still a long way.
Oh, I see. Dr. Rubin, what about antiviral drugs? What about the latest stage, according to your information?
Well, there are a few drugs that are under investigation right now, and they have different properties. Some of them are widely available and inexpensive, and some of them are not fully approved yet and won't be widely available even if they turn out to be successful. So they're not necessarily going to be transformative by themselves. I think that, as Dr. Du said, a vaccine that was highly effective, if we could make one, would be transformative. It would completely change what we do. But we don't have one of those yet, and we won't have one for a while.
One of the crucial questions I want to ask both of you is, we have seen, Professor Rubin, from Wuhan, that some of the already treated patients who were discharged from the hospital, quote-unquote, got reinfection. Now, there are two possibilities. One is possibly reinfection. The other is, well, the test only showed they were negative, but it's not, before they were discharged from the hospital. So, Professor Rubin, what about the danger of reinfection? And what about some suspect, with the rest of the world now fighting against this pandemic in their own way, the bigger possibility of danger once again for China later? Professor Lu.
Well, my personal belief is that the majority of these patients, that the concept of reinfection in COVID-19 during such a short period after recovery doesn't make any sense. My own judgment goes like, we have different manufacturers with regards to the PCR test kits. So I do understand, I do know that they could produce conflicting results in some instances. And I do believe that the so-called reinfection, which actually meaning that the test can become positive again, just reflect the facts that the novel coronavirus can exist in somewhere in your body, in the patient body, for quite a long time, that the viral shedding can happen or can occur from time to time.
Yeah.
This is not new finding. That it is true for Ebola. virus. It is also true for some other common, virus like the herpes, like the CMV virus.
I agree entirely with Dr. Du. He has, of course, the benefit of having taken care of so many patients, and so he has real observations. But from what we know of this type of virus, generally, once it clears, it clears. However, the tests are not perfect. And as Dr. Du said, for many patients will have negative tests before they have their first positive test, and chances are they were falsely negative, that you just missed the virus. And that could be because the tests aren't perfect, but it could also be that when you stick a swab in their nose or in their throat, you're only getting a small sample, and it's just missing part of the secretions where the virus was. So I think it's likely to be more of an imperfect test than real reinfection or relapse.
Dr. Eric Rubin from the New England Journal of Medicine based in Boston, thank you so much for joining us. And Professor Du Bin with us in Wuhan. Do stay with us. You're watching The Frontline, devoted to the fight against COVID-19 pandemic. Stay with us. We'll be right back. And you're watching The Frontline. I'm Tian Wei. We're now still joined in Wuhan by Professor Du Bin, Director of Medical ICU at Peking Union Medical College Hospital. Meanwhile, in Boston, we have David Jones, Professor of Culture and Medicine with Harvard University. Professor Jones, welcome to our program. Professor Du, thank you for staying with us. Professor Jones, first question to you. We heard so much about the latest debate about so-called herd immunity, and that has created an uproar about what strategy to take globally as well. Your take?
Well, I would say as a historian that one thing we know very well is that humans have been struggling with epidemics for thousands of years, for as long as we have lived in cities. And we have learned much from this history. We know well the chaos that epidemics can cause in society. We know that epidemics can bring people together, and they can also tear us apart. We've also learned many ways to control these epidemics, whether it's through quarantine, isolation, or immunization. Unfortunately, there's also much that we don't know. We don't know whether this epidemic will behave more like SARS or more like influenza. If it's like influenza, we would expect the epidemic will fade over the course of the spring, but then might come back with a vengeance in the fall, which is what happened in 1918. If it behaves like SARS, the epidemic might will run its course over the spring and hopefully clear in the summer. Now, one of the questions about herd immunity depends on which of these past epidemics coronavirus is more like. There are some diseases for which herd immunity is very relevant, and if corona behaved that way, it's possible that that strategy would work. But we just don't know.
Yeah. And
since we can't tell which past epidemics this is most like, it's very hard to make the best decisions right now.
Professor Du Bin, as the director of the ICU unit on the front line, let's take a look at the question from another perspective. What you wished the societies would do, or all sectors would do, so that you did not have to end up in a devastating situation with your colleagues to make a last resort effort?
We were discussing about the concept of the herd immunity. I think one of the major things that came to us is that whether or not, or how effective can we control the number of diseased patients. Or, as we just said, that around 20% of patients had respiratory failures secondary to the COVID-19. So who should be admitted to the hospital for further treatment? So if the herd immunity came into play or come true, that we should be very cautious at controlling the number of those moderate to severe cases in order to ensure that we have enough healthcare resources to treat the patient, which is, in my mind, will be very difficult. Yes.
It's an interesting answer. I think it's thought-provoking. Professor Jones, I know you're mainly researching about the culture and the history of pandemics. From your perspective, what does it mean, what Professor Du just said? You know, that extreme challenge and probably difficulty at a huge outbreak when you have to choose very carefully as to who to treat or who not to treat, and that lines could be blurred. Would that be even more difficult than controlling on a bigger scale, Professor Jones?
Well, I think both of those challenges are huge challenges. Everyone agrees that the best thing to do is to prevent the number of cases we have, because with so many people, with 20% becoming seriously ill, if a lot of the population becomes sick at the same time, that will create a huge stress on the healthcare systems. One of the things that's so different from 1918 is we now have incredible medical technology that allows us to keep alive people who wouldn't have survived in 1918. And it's wonderful that we have access to this technology. But the real challenge is trying to make sure that the technology can be given to everyone who needs it. And if too many people show up at the hospital at the same time, then difficult decisions need to get made over who should receive the technology and who will have to get by without it.
Yeah.
And the best way to prevent those decisions is by having aggressive control measures in place. And that's why so many cities are trying so hard right now.
Of course, control measures come in different layers. You said, Professor Jones, once, if I could quote here, the history of epidemics offers considerable advice, but only if people know the history and respond with wisdom. Now, about wisdom, I want to come back to Professor Rubin from China. Now, China has, I'm not saying China's way is everybody's way, but you probably could help us who are trying to jump into this pandemic anew in a way to understand what is the different layers of treating emergency in China. You know, what about community? What about ICU? What about the overall separation of the severely ill with the others? Tell us more about that, Professor.
I should say at the community level, if we ask those who might be the patients, mild cases with COVID-19 stay at home, to isolate themselves at home, you should provide a very strong or adequate community support, not only the consumables, but also the medical advice, how to avoid the human-to-human transmission within the family and with their, neighbors, let's say. And you also have to provide, enough medical care whenever the patient develops the, transferred from the mild cases to severe cases, which can be true because a majority of our patients have developed the signs, symptoms of the respiratory distress since the second week. So during the first week, they are doing okay, because only fever, only a mild symptoms. But however, from the 5 to 7 days, there is a much severe, clinical deterioration, indicating the presence of the developments of the acute respiratory failure. So you must have your own way to help those patients who became more severely ill, and to identify them and then transfer them into the hospital. And from the hospital point of view, I should say that even for the high-income countries like the States, like European countries, that whenever you have a surge of the most critically ill patients within a relative short period of time, you are running out your resources. You are running out the ventilators. So you became a resource-limited, scenario.
Yeah.
So you should have your own plan, at the hospital level, that whenever the surge of the critically ill patient became true, that how to expand your ICU capacity within a relatively short period of time, and how you can find human resources who can serve the patients, who can taking care of the patients at the ICU, that sort of things. Yes.
Professor Jones, your response.
No, I couldn't agree more about the importance of having this preparation in place. You know, one of the things that we see here in Boston is even though we have several very large hospitals with great capabilities, most of those hospitals are already full of patients at baseline. The goal of any modern hospital is to run at 95 or 100% capacity. And then when you have something like an epidemic put on top of that, the question isn't just how to treat all the people who are sick because of the epidemic, but also how to continue to treat the people in your population who had been needing medical care all along, patients with heart disease, patients with cancer, patients with other kinds of problems. And so you're really trying to figure out both how to respond to the new needs of the epidemic and then also how to preserve care for the people who have always been sick all along. And that is a really serious challenge that we're just trying to figure out now how to manage.
It's a very hard balance, and we are all trying to learn during this fast developing pandemic. Before we go, to let you go, Professor Jones, I want to read some questions coming from our users and also those who are being raising questions from CGTN Facebook and Twitter accounts. People asking, suppose in case we were infected, you know, earlier both of you have been talking about what if the mild symptoms. Suppose we were infected by coronavirus, what common medical treatment should be taken? So what advice would you give? Professor Du, you go first, and then we have Professor Jones.
It's hard for me to say any effective treatment because, as Professor Jones just said we don't have enough, effective antiviral therapy for the coronavirus, the novel coronavirus at this stage, and we don't have the vaccine yet. So just to be cautious about any abnormalities with regards to respiratory distress, which might develop after 5 to 7 days after the onset of fever. So this is a signal or sign that you should see the doctors. You should seek medical care rather than staying at home. Yes.
Okay, Professor Jones, your advice before we go.
Sometimes in an epidemic like this, often the old advice is often the best advice we can give. In the absence of specific treatments for a disease caused by a virus, we can rely on ancient wisdom that one thing you can do to keep yourself healthy is to try to sleep as much as you can, to make sure you're having adequate food, to make sure you drink lots of water. And all of these things are old bits of medical wisdom, but they can be very useful in helping people who have mild illnesses get through this and keep themselves healthy. The other thing that's always important to pay attention to is keeping track of people's mental health during an epidemic. These long periods of isolation can put great strain on populations. And the last thing we need is to have an epidemic of anxiety and worry to make the physical illness worse than it actually is. And one piece of reassurance I can draw from history, and I might be naively optimistic here, is that over the course of human history, catastrophic epidemics have been very, very rare. There are only a handful of times an epidemic has spread around the world and killed millions of people. I hope we're not in one of those situations now, and I'm very hopeful because of the experience that China has had bringing this epidemic under control in China, that if we are able to get our populations to work together, to do the right thing, to pay attention to the public health officials, I'm really hopeful still that we'll prevent a catastrophic epidemic.
This is the Frontline. I'm Tian Wei. We are joined now by Professor Rubin, Director of Medical ICU at Peking Union Medical College Hospital. Meanwhile, we are also joining Washington, D.C., Dr. Kate Tulenko, CEO of Corvus Health, a well-known health expert who served in the WHO and the World Bank. Dr. Tulenko, good to see you once again. Thank you for joining us.
Thank you.
Dr. Tulenko, you've been working so much on how to, from the public health perspective, to manage the situation, how to manage hospitals at a crisis. Tell me more about the preparation now going on in the U.S. and how is that compared to what you have witnessed in China over the past 2 months?
So right now there are three main emphases. One is to get more testing kits out and the testing kit reagents and equipment so we can test more people, know their status, segregate patients in hospitals between COVID positive and non-COVID positive. And then the second is protective equipment for health workers so that we can keep them safe and also keep them from infecting patients as well. And then the third is the shortage of ventilators and ramping up production of ventilators, coming up with alternatives, teaching people how to put several patients on a ventilator. So those are the three main ones that we're working on. And in comparing across different countries, it's extremely difficult because the structure of the health systems are very different from the perspective of the number of beds per population to the way health workers care for patients. One thing that we can look at, and is quite interesting, is the level of the protective equipment that's been supplied and how many health workers have become infected. For example, we know in Singapore, not one single healthcare worker has been infected. And you can compare that to Italy, where about 10% of health workers have tested positive. Compare it to Iran, where in one area, 40% of all positive patients were healthcare workers. Yeah. And in China, where in one hospital, 30% of all patients were healthcare workers. So obviously there's a difference in not only the type of protective equipment people are using, but the way they're using them and getting infected or not. So I think those are very important issues.
About those issues, do you have any specific questions for Professor Rubin from the front line at the epicenter?
Oh, absolutely. It would be what he has found most effective in protecting healthcare workers from the coronavirus.
Professor Du.
For those who are not involved in the high-risk procedures, that I do believe that the most effective way to prevent any contamination or infection, transmission of the virus, is the N95 face mask, as well as hand washing. And from my visit to different hospitals here in Wuhan and in other cities in the Hubei province, it is very common for us to see the doctors and nurses in the general wards or ICUs that they have PPEs, personal protection equipment, such as the goggles or face shield, the face mask N95, and they have coverall in addition to the long-sleeved gowns, and some of them even have boots. I understand, especially for ICU doctors and nurses, you never know whether you will involved in high. Whenever you enter the intensive care unit, you have no idea whether there will be a high-risk procedure happening during your duty. Probably the patient needs endotracheal suctioning. Probably a patient requires urgent, endotracheal intubation.
Dr. Tulenko?
Well, I also think we're seeing a lot of innovation, particularly coming from South Korea. South Korea was the first country that did the drive-through testing areas, and the U.S. is starting to repeat that now, as are other countries. We've also seen in South Korea the idea of putting the healthcare worker behind a plexiglass shield with rubber gloves extending through, so that people who don't have cars can just walk up to the healthcare worker protected by the shield and be tested that way. And so we need more type of innovation like this. Yeah. And a perspective that I have is that, in many health facilities where the patients haven't yet been segregated between COVID positive and COVID negative, basically needing to treat every patient as though they're COVID positive. Right. So that would involve being able to provide all healthcare workers with both the masks and with gloves, as Professor Du mentioned.
Yeah. Professor Du, do you have any questions specifically for Dr. Tulenko, as she is there on the ground in the U.S. about the latest situation, and she's been doing research about the hospital management?
We're currently not quite sure about the risk of the transmission of the droplet transmission in terms of in patients who are requiring the non-invasive mechanical ventilation, or in patients who have been treated with a high flow nasal cannula. I wonder if the doctor can give us any, advice or any, suggestion for that.
Dr. Tulenko.
Yes, well, this has certainly been very controversial, and the CDC recently changed its guidelines from respiratory precautions to droplet precautions, which is lowering it from the N95 to the basic surgical mask. And I think that there's a lot more that we need to understand about this virus to find out, how it's transmitted and what protects healthcare workers. So it remains to be seen about that. But we've certainly learned a lot from our Chinese colleagues. I think one thing that we've learned is that measuring the blood ferritin levels, ferritin is a basic component found in blood, that the ferritin tends to spike in patients that are going to have this cytokine storm. Because it turns out that it's not the virus per se that kills people in a classic way that influenza virus and the influenza pneumonia kills people, but it's this cytokine storm of the body's own immune system attacking the lungs that tends to cause a lot of the mortality. And certainly I think a very important thing that healthcare workers need to do now is share data and share information, because certainly the data that our Chinese colleagues have provided us has been very helpful. And I think that, unfortunately, as more data is gathered in Italy, in the U.S., the UK, and elsewhere, we'll be able to share that data and find out how to help our patients. Because it looks like chloroquine might be able to help. We're also finding out that it looks like ibuprofen might make things worse. Yeah. But we need to find every treatment an advantage and use that.
So are we going to see a united effort to curb COVID-19 pandemic? If not, what kind of danger we're facing in terms of medical challenges and also scientific challenges and certainly human disasters?
Well, I should say this is a global issue rather than a national issue, because we are not alone in fighting against this coronavirus, novel coronavirus. Even though we have a smaller number of the newly diagnosed cases, we are still in the threat of the, facing the threat of the imported cases, like what has been happened during these days. So whenever every nation or globally we are doing the right thing, that we are safe.
China so far has 123 imported cases from 9 countries. Dr. Tulenko, same question.
So I think we will be united as a global medical community in sharing best practices and data, but unfortunately I think we're divided as far as the approach that many governments are taking. So we're seeing the closing of borders, and I think that unfortunately every country is going to need to look at producing its own protective equipment, ramping up production of ventilators and even pharmaceuticals. In fact, in the post-corona world, I think you will see a much more distributed manufacturing world. There won't be the high concentration in China as there was before.
We'll see what happens from now on. And first of all, of course, the COVID-19 pandemic that we have to deal with. Kate Tulenko, Professor Du Bin, thank you so much. Especially Professor Du, you've been sitting with us throughout the hour, providing the updated information from the epicenter, Wuhan. Really appreciate it. And that's all we have for our special production, The Frontline, on global efforts fighting against COVID-19 pandemic. If you'd like to see more, you can visit our website. Just type World Insight CGTN into your search engine. You can find us. Also check out our YouTube channel, Twitter, and Facebook accounts. From me, Tianwei, and everyone on the World Insight team, thanks for watching. Bye for now.